Assalamu alaikum. This presentation is on the use of laser in microlaryngosurgery for benign vocal fold lesions in patients with voice disorders. We shall go through the design and dissection of a vocal fold microflap and the settings and parameters of carbon dioxide laser in laryngosurgery for benign vocal fold lesions, together with the settings for also KTP lasers in some of these lesions: vocal fold polyps, nodules, cysts, Reinke's edema, sulcus vocalis, mucosal bridge, arytenoid granuloma, and vocal fold vascular lesions. This is a coronal section of the vocal fold vibrating edge, which would help to explain the anatomical basis for microlaryngosurgery. The majority of the benign vocal fold lesions under discussion arise from the cover part of the 5 layers of the vocal fold, that is to say, the epithelial cover and the superficial part of the lamina propria. That's why it's important to master the microflap technique, in which as little as possible of the epithelium and an adjoining part of the superficial part of the lamina propria, the microflap is elevated. The vocal fold epithelium may regenerate with time to cover any defect, but then the anchoring microfibers of the epithelium to the underlying basement membrane and the superficial layer of the lamina propria may not re-establish. The superficial layer of the lamina propria is vital in the production of the normal mucosal wave during phonation, and unfortunately has a poor regeneration power, so it must be maximally preserved if possible. The other thing is the vocal ligament, formed of the deeper parts of the lamina propria, the elastic and the collagenous fibers in the lamina propria. If traumatized, they would induce proliferation of fibroblasts and subsequent fibrosis in the area, and this would cause scarring and vocal fold stiffness and can affect phonation. The dissection of a vocal fold microflap would start with infiltration of the rhinic space with 1 or 2 milliliters of 1 in 10,000 saline adrenaline mixture into this subepithelial space prior to any incision. A lateral incision can then be carried out using laser or sharp instruments to enter into the rhinic space, the superficial part of the lamina propria. And then blunt dissection would be helpful to lift the epithelial cover together with an adjoining small part of the superficial layer of the lamina propria, forming the microflap. Care must be taken not to injure the vocal ligament. The vocal ligament injury would induce fibrosis, and this ultimately is going to cause vocal fold stiffness. This is the vocal ligament, the whitish structure in there. The infiltration of the saline adrenaline would help in achieving hemostasis, also would help in the hydrodissection and with the ease of lifting the epithelium and part of the lamina propria, and will also work as a heat sink in laser surgery. It would dissipate the heat from laser surgery and avoid direct injury to the vocal ligament. The absence of elevation of the epithelium during the infiltration with the saline adrenaline mixture may indicate that the lesion is actually attached to the vocal ligament. The adrenaline mixture would then just form a circle around the lesion that would not be elevated, forming what is called a donut effect. 3 important physical concepts need to be considered in laser surgery: the ablation threshold of the target tissue, the thermal relaxation time of the target tissue, and the pulse matching the on and off timing of the laser beam. Basically, for the laser to work in incising or ablating certain tissue, it needs to raise up the temperature of the tissue above a certain threshold. This is the ablation threshold. For water, for example, which is the target tissue of carbon dioxide laser, this temperature, the ablation threshold, is 100 degrees centigrade. If the laser does not raise up the temperature to 100 degrees centigrade, the heat generated by the laser will just dissipate into the surrounding tissue and cause collateral damage. It needs to reach that threshold in order to cause the cutting or the ablation of the target tissue, vaporization of the water molecule. Even after reaching this temperature, the target tissue would quickly lose the temperature over very short period of time. In the case of water, again, the target tissue of carbon dioxide laser, the time needed to lose 50% of the 100 degrees centigrade, that is about 50 degrees centigrade, is very short, is less than 1 millisecond. It's actually 0.8 milliseconds. So for the most effective way of laser delivering is to deliver laser in very short but intense pulses to raise up the temperature above the 100 degrees centigrade, cause the cutting or the ablation, and then allows for the tissue to cool down before the next pulse hits the target tissue, again to raise up the temperature to this amount. In a continuous mode for the laser, the intensity of the beam is quite low. It may not reach the ablation threshold quickly, and there is a lot of dissipation into the surrounding tissue and collateral damage. In the super pulse mode, the cone shaped, and in the ultra pulse mode, the rectangular shaped, the threshold is reached very quickly, more quickly in the ultra mode, of course, because it's almost vertical. And this would cause the cutting or the ablation, and then allows for the cooling of the tissues before it starts the next pulse. A very short and sharp pulse, like the red trace in here, is more effective than a collateral damage causing pulse in the orange curve, which does not reach the ablation threshold and dissipates the energy into the surrounding tissue. A very common setting of carbon dioxide laser for laryngeal microsurgery is this, the pulse mode, either super pulse or ultra pulse mode, with the lowest possible power, 2.5, usually somewhere between 4 to 6 watts, but as low as 2.5 for work on the vocal folds, and 10 watts if you are working on a bigger job like papillomatosis, for example. And this should be delivered in short pulses, like 50 milliseconds or 100 milliseconds. This is very short pulse, and a longer off interval for cooling down of the tissue, half a second, 500 milliseconds, concentrated into a very small spot, like 1/4 of a millimeter spot. But if it's used to cut into a line, this would be 1 or 2 millimeters in length, and this line can be curvilinear, a bit longer, 1 to 2.5 millimeter in length, curved to the right or curved to the left. And the depth of penetration would usually be set between 1 and 2, which is 1 is equivalent to 1/4 of a millimeter and 2 to half a millimeter. The continuous wave mode is used only very briefly, if at all, and then for coagulation or on very thin lesions. We move now to the laser in specific vocal fold pathologies, starting with vocal fold polyps. The settings here would be through a jet ventilation, a 1.5 millimeter spot size, because it's a line in here, with a penetration of only 1 millimeter. The watts would be either 3 or 4, single pulse or super pulse mode with 50 milliseconds pulse duration and about 300 or 500 milliseconds off. The polyps can usually be accompanied by a feeding vessel, and this should be coagulated to prevent any chance of recurrence. But basically, we are using the laser here to cut down the base of the polyp with minimum loss of epithelium, so that the mucosal wave would be regained very quickly. There is often a contact lesion on the contralateral side of the vocal fold polyp that may require attention during surgery. Now, the issue of preserving as much epithelium as possible to regain the mucosal wave quickly. The epithelium above the polyp itself is usually very thin and atrophic, and it's not worth preservation. On cutting the base of the polyp, we'll discard with that the polyp and its overlying epithelium, but we try to preserve the stretched infraglottal epithelium, because this is the epithelium that can be used to redrape the vocal fold edge and prevent any raw surface. Naturally, different surgeons would use different laser parameters for the same operation. This can be as little as only 2 to 3 watts in a super pulse mod. The spot size can be as small as 0.2 millimeters to shave the polyp, or you could use a longer linear or curvilinear with 1 or 2 millimeters rather than just a fifth of a millimeter spot size. Some surgeon had used the carbon dioxide with only 2 watts in super pulse mod, a very tiny spot, 200 milliseconds pulse on and 500 milliseconds pulse off. Many other surgeons used somewhere between 3 and 6 watts, again with the beam either focused into a very small spot or a straight or curvilinear line. In short bursts, it was 200 here, it can be 100 milliseconds on for others, and off between 300 and 500 milliseconds. The super pulse mode is strongly preferred. We move now to vocal nodules, particularly hard vocal nodules. Surgery is not the first line of treatment, but when to consider surgery. It can be considered in a very small number of patients with vocal fold nodules, but virtually never should surgery be performed without adequate trial of expert voice therapy. And it can be considered if the symptoms and the pathology is refractory to the maximum and compliant voice therapy. This is usually the case with mature vocal fold nodules that can be best managed by surgery rather than prolonged voice therapy. Also, nodules that have atypical features like asymmetric or irregular or suspicious nodules. The laser settings for vocal fold nodules can be somewhere between 4 and 6 watts in a super pulse mod. The microspot mod would be 0.2 millimeter beam. In a quite large series of laser surgery from India, all the operations were carried out with a 6 watt super pulse mod. Some surgeons would even use lower watts, like between 2 and 4 watts for very thin nodules. It's super pulse mod with about 100 milliseconds on or 50 milliseconds on, with a cooling interval of about 500 milliseconds to limit the spread of the thermal damage. And rather than using a microflap technique, the laser is just used with the micro spot or with the curvilinear to shave off the nodule from the edge of the vocal fold mucosa. A steroid injection may be considered after the end of operation, and this can help in reducing the inflammatory process and preventing further scar. Carbon dioxide laser can also be used for incising a microflap to resect a vocal fold cyst. This should be carried out as lateral as possible and between the cyst and the vocal ligament. Once the incision is carried out by laser or sharp instruments, the microflap is now dissected. You could see the cyst in the bottom in here, and every attempt should be carried out to preserve the wall to prevent recurrence or further scarring. The usual settings would be with the super pulse mod, 2 watt or a bit more, and very small penetration, only to incise the superficial part of the epithelium here to gain access to the lamina propria. The key is to vaporize only the superficial tissues in here without deep injury to the cyst or to the vocal fold ligament. If the cyst ruptures, then complete removal of the cyst wall must be achieved. Search for all the remnants. And this is a summary of the laser settings in the commonest 3 conditions for vocal fold benign lesions: the polyps, the nodules, and the cyst. And the laser mod The recommended laser mode would be the super pulse with a microspot. For the three of them, the power would be anywhere between 2 to 6 watts, and the spot size as small as possible, almost a fifth of a millimeter, unless you are using a linear or curvilinear line, which can be a bit longer. And the pulse on and off, the pulse on would be between 50 and 100 milliseconds on, and around 300 to 500 milliseconds off, to allow for the cooling of the tissue in almost the three of them. In microlaryngosurgery for Reinke's edema, there is no need for subepithelial infiltration of adrenaline saline mixture, because the vocal fold epithelium is already raised off the vocal fold ligament by the lesion itself. An incision has to be carried out for the microflap lateral chordotomy, and this can be best carried out by a laser on the superior surface of the vocal fold as laterally as possible, starting at the level of the vocal process of the arytenoid posteriorly and advancing anteriorly towards the anterior commissure, but stopping at least 3 millimeters from the anterior commissure itself to prevent any chances of webbing of the commissure and glottal stenosis. Then different surgeons would use different settings for this type of operation. This can be as low as 1 watt with pulsed mode of 50 milliseconds and slightly defocused beam to cover a wider area with a smaller amount of energy. In contrast, this can be as high as 10 watts, again to incise the superior surface of the vocal fold by linear incisions of 2 to 4 millimeters long and 0.27 millimeters wide and only 0.2 millimeter in depth. And once the incision is carried out, it can be the flap can be elevated, and the elevator can be used to separate the polypoid tissue from the overlying epithelium and the underlying vocal ligament. The excess material in the superficial part of the lamina propria can be removed either with a strong suction or with a cup forceps, but would need to avoid overzealous removal of the tissues from the rhinic space, particularly in men, because if this has happened, if there is excessive removal of material from the rhinic space, the voice can have a very high pitch after the operation. Reduction glottoplasty, lateral chordotomy, or lateral microflaps, three names for almost the same procedure as first described by Herano almost 40 years ago. The surgery is started with an incision on the lateral part of the superior surface of the vocal fold. This can be done by laser sometimes or a sharp sickle knife. Then the submucosal layer is entered. This is the superficial part of the lamina propria. You can see the deposits in here. This should be dissected off the vocal ligament to avoid any injury to this whitish structure, the vocal ligament. Then the material in there, the deposits, can be aspirated, sucked out, or removed by cupped forceps, or sometimes vaporized by laser. Then the epithelium will be redraped over the vocal fold to see if there is any excess mucosa that should be trimmed. And once this is achieved, then some injection of steroids in the vocal fold would tend to help in healing without too much fibrosis, and also the vocal fold surface can be sprayed with lidocaine to decrease the chance of laryngospasm on extubation. Remember that extensive resection would lead to more than average fibrosis and may not provide good post-operative voice results. These linear furrows in the epithelial cover of the vocal folds can have variable depth. They can reach as far as the vocal ligament and beyond to the thyroarytenoid muscle, or they can be superficial with only a small dip into the superficial layer of the lamina propria. They were first reported by an anatomist, which is not surprising given that the incidence of sulcus vocalis in cadaveric larynxes could reach as high as 20%. Only very few percentage of them would be symptomatic and would present to an ENT surgeon or a laryngologist. It's considered one of the most difficult lesions to diagnose and treat in the vocal folds pathology. They cause glottal dysfunction with impaired glottal closure, a breathy component to the voice, and consequently vocal fatigue and phonoathenia. They also stiffens the vocal folds, and the mucosal waves would be disordered, and the voice would have a higher pitch and would be perceived as rough and breathy. The management of sulcus vocalis cases should have two aims. The first is to restore the mucosal wave that has been disrupted by the presence of the sulcus, and the other is closing up of the phonatory gap caused by the medial edge bowing in the case of sulci. A trial of voice therapy is the usual starting point, particularly in mild cases like type 1 sulci. This may be all that is required, and the voice would improve and can be satisfactory to the patient and will also avoid all the hazards of the surgical intervention. But many cases, particularly type 2 and type 3 cases, would require surgery that should be very precise in order to remove all the sulcus remnants, which is not an easy job, and should also be very conservative in order to reduce the amount of post-operative scarring and reduce the amount of resection of the mucosal cover of the vocal cords that can lead to further stiffening of the vocal folds. The post-operative voice therapy is essential and can extend up to 9 months. Other consideration would be the correction of the phonatory gap post-operative or intraoperative by medialization procedures of the vocal fold like thyroplasty, or augmentation of the vocal folds by injection or by implantation of fat and similar materials. The oldest and the commonest procedure is excision of the sulcus vocalis and reapproximation of the epithelial edges. It starts with subepithelial infiltration with adrenaline mixture with saline, and this would help in delineating the sulcus and also would cause lifting of the sulcus of the surrounding tissue by hydrodissection, followed by chordotomies, elliptical incision around the orifice of the sulcus, better made with lasers. This is then followed by very meticulous subepithelial dissection of the sulcus, particularly of the vocal ligament and beyond. The aim is to cause the least amount of scar tissue, particularly around the vocal ligament, and to remove the least amount of the epithelial cover, because this could lead excessive removal, and excessive scarring could lead to further vocal fold stiffening. Once the sulcus is removed, the gutter between the vocal ligament and the epithelial edge could be obliterated by approximation of the two epithelial edges and suturing them with either 5 or 6O absorbable material or by the use of glue. The surgical removal of a vocal sulcus would start with incising the epithelium of the sulcus from the surrounding vocal fold epithelium and the tissues in the deeper part of the sulcus groove, particularly the vocal ligament. This is best carried out with carbon dioxide laser, sometimes at a higher power of 10 watt, in order to cut long incision lines of 1 or 2 millimeters to a depth of 0.2 millimeter penetration and 0.27 millimeter width of the incision line. Once the epithelium is detached from the surrounding vocal folds and from the deeper part of the groove, they can be dissected meticulously from the bottom of the groove and the vocal ligament if it's attached to it. This can be carried out with blunt dissection. At the end of the operation, the vocal fold bowing should be corrected by a medialization process, particularly if the glottic gap is about 1.5 millimeter or so. Procedure can be carried out by lipo injection or a type 1 thyroplasty operation. Examination of the larynxes of patients with mucosal bridges may not show the lesion at all. Either the use of flexible laryngoscopy or direct laryngoscopy may not show the lesion. It may show an abnormal blood vessel pattern that would suggest the presence of a lesion. Stroboscopy could also suggest the presence of the lesion if there is a sudden reduction in the vibratory pattern over one area. The stiffness of this area would suggest either a vocal fold sulcus or a mucosal bridge, and only direct microlaryngoscopy under anesthesia with palpation could tell the difference between a mucosal bridge and a vocal fold sulcus. The management of vocal fold mucosal bridges should focus on two things: restoration of the vocal fold mucosal wave and closing the glottal gap caused by the glottic insufficiency. A trial of voice therapy is always a good start, particularly when the symptoms are mild. but many patients will require surgery that has to be very precise in order to avoid any excessive mucosal resection or any excessive postoperative scarring or any injury to the vocal ligament. And postoperative voice therapy in all cases would be mandatory. The second focus is the glottic gap, and this can be sorted out after resection of the mucosal bridge by either fat injection or fat implantation, or using collagen rather than fat, or medialization procedures like type 1 thyroplasty. If surgery is indicated, microlaryngoscopy under anesthesia would be the best choice to resect only the undersurface of the mucosal bridge, not the whole of the mucosal bridge, just the epithelial cover of the undersurface of the mucosal bridge. Exposure of the bridge area can be improved by averting the medial edge of the vocal fold. Gentle pressure on a pledge placed laterally on the superior surface of the vocal fold would help in this aversion. And once a good exposure is achieved, the mucosal bridge is incised and only the undersurface epithelium is removed carefully, leaving the outer surface epithelium and the core of the connective tissue in sight, followed by removal of the epithelium overlying the vocal ligament of the vocal fold carefully so as not to injure the vocal fold ligament itself and not to cause any excessive scarring in the area. Once the two epithelial surfaces, the opposing surfaces, are removed, the remnant of the mucosal bridge with the outer cover and the core of the connective tissue are then draped over the vocal fold or glued in place in order to help in restoring the mucosal wave. After this, consideration should be given to any procedure necessary to close any glottic gap by fat injection or implantation or type 1 thyroplasty. The use of pulsed dye laser fibers can greatly improve the precision of the surgical intervention. The laser fibers are used to remove the epithelium from the undersurface of the mucosal bridge and the corresponding area of the vocal fold, and once the raw surfaces on the two sides are clear from any epithelial remnants without any injury to the vocal ligament itself, then the mucosal bridge remnant formed by the outer layer of the mucosal bridge and the core of the connective tissue can be draped or glued to its original site on the vocal fold. As you can see, the pre-operative glottic gap has now disappeared after surgery and the mucosal wave was restored. The carbon dioxide laser settings, if that's used in the resection of the mucosal bridge, should be low power and pulse. It can be somewhere between 4 and 8 watts. Other surgeons have used a bit higher power, but the pulse should be about 100 milliseconds on and 500 milliseconds off. And the usual is that you would have the focus as a spot about 200 to 300 micrometer spot to incise the bridge band epithelium. And this table summarizes the carbon dioxide laser settings in the last three conditions: the Reinke's edema and the vocal sulcus and the mucosal bridges of the vocal folds. You would notice some differences here between the Reinke's edema and the other two, in that in Reinke's edema you would use a much lower power, sometimes as low as 1 watt in a pulse mode, and that's basically because you are just using it to incise the superior surface of the vocal fold to gain access to the Reinke's edema, whereas you are using the power here to de-epithelialize the vocal sulcus epithelium or the undersurface of the mucosal bridge. The mode of the laser delivery would be pulsed in the 3, like a super pulse with about 50 milliseconds on and somewhere about around 300 to 500 milliseconds off. In Reinke's edema, you would want a wider spot in order to decrease the density of the power, so it can be up to it can be a defocused beam up to 300 micrometers. And the vocal sulcus and the mucosal bridge, the cuts will be usually linear, like 1 to 2 millimeters, in order to deepithelialize the structures. Again, the pulse duration and the frequency is usually 50 milliseconds on and about 500 milliseconds off for the Reinke's edema. That's a very short pulse duration compared to the usual 100 milliseconds on, and again 500 milliseconds off for the other two conditions. The main lines of treatment for arytenoid granulomas include things like reducing the effect of laryngeal irritants, stopping the smoking, improving vocal hygiene, treating any respiratory tract infections or allergies, and control of laryngopharyngeal reflux. Voice therapy is also a mainstay in the management of arytenoid granulomas, with raising the awareness of the condition, reducing the hyperfunctional element of the voicing, and preventing any voice misuse or abuse. There is no good evidence to support the use of antibiotics in general, only in very selected cases where chronic inflammatory processes in the cartilage are suspected. Symptoms may improve by inhaling steroids or even systemic steroids, again in selected cases. Nebulizers can decrease the throat irritation. Surgery in the form of microlaryngosurgery should be a last resort in the management of arytenoid granulomas. Surgery alone does not cure arytenoid granulomas, and there's a very high chance of a recurrence. But surgery is helpful in confirming the diagnosis and excluding a sinister pathology, and can also be helpful in debulking a large lesion that may threaten to compromise the airway. If surgery is chosen, then lasers usually gives a better success rate, and they also reduce the amount of bleeding from these vascular lesions. Care must be taken to avoid any thermal injury to the underlying cartilage during vaporization of the lesion. A pulsed laser, sometimes dye lasers, has been used with success, and following the removal of the granuloma, one may consider the use of local steroids or even mitomycin to help in preventing a recurrence. There is also a need to consider the use of Botox injection in the thyroarytenoid muscle, small amount like 5 to 8 units, to reduce the impact of the adduction that may help in the recurrence of the granuloma. Both carbon dioxide lasers and KTP lasers may be used in the surgical management of arytenoid granulomas. The power is usually about 2 to 4 watts if it's used in the pulse mode, or 6 to 10 watts in the super pulse mode for carbon dioxide, and 3 to 7 watts in continuous or pulse mode for the KTP. The mode is either pulsed in single pulses or super pulse in the carbon dioxide and pulsed only for the KTP. The spot size is a bit bigger. To ablate the granuloma should be somewhere between 200 and 400 micrometers in the carbon dioxide case, and a bit larger, 400 to 600 micrometers for the KTP. And the pulse duration here is between 50 and 100 milliseconds. A shorter pulse duration is used with the single pulse in KTP between 10 and 50 milliseconds. And the advantage of using the KTP is that it causes destructive, selective destruction of the hemoglobin into the granulation tissue. The carbon dioxide laser is used to ablate the whole of the granuloma. Vascular lesions on the surface of the vocal folds can be one of two different categories. The longitudinal vessels parallel to the edge of the vocal fold are usually associated with phonotrauma, and the vessels that run perpendicular to the edge of the vocal fold are usually associated with pre-malignant or malignant lesions of the vocal folds. We limit ourselves to the longitudinal vessels associated with phonotrauma and their potential to cause vocal fold subepithelial hemorrhage. They can take different forms, from a varix, like a varicosity of the vessels in here, or a minor when it has too many twists and turns, or even telangiectasia and raised up lesion on the surface like in ectatic blood vessels. The patients who would benefit from surgery are the patients who present with recurrent hemorrhages in the subepithelial part of the vocal fold, or if the patient has an associated mass lesion like a polyp, a vascular polyp in the vocal fold, or describes a voice limiting symptoms, or has the lesion on or nearby the medial edge of the vocal fold, the vibratory margin that may interfere with the vibration or the glottic closure, or when the symptoms of dysphonia or voice fatigue is caused by a vascular lesion that engorges during heavy voice use, like long singing, or of course if there is any suspicion of a sinister underlying pathology in perpendicular blood vessels, and to evacuate a hematoma in case of acute subepithelial hemorrhage that does not settle conservatively. On the other hand, the patients who may not benefit from surgery, and so there is no strong indication for surgery, are the patients who are asymptomatic and their lesions does not look like there is a significant risk of hemorrhage, or in patients who have vascular abnormalities that is related only to the menstrual cycle, because these can be treated by hormone therapy, or in patients who have telangiectasia associated with Osler-Weber's-Rendo syndrome, or in professional singers, particularly the high sopranos, who have minimal symptoms because of the increased risk of adverse effects on their performance that can be associated even with minimal post-operative stiffness. This can outweigh any benefit of surgery. We've been through this before. The laser wavelength relative to the tissue absorption coefficient is important because maximum absorption of the tissues would occur when the wavelength of the laser matches the absorption coefficient of the target chromophobe. And for oxyhemoglobin in the vascular tissues of the vocal fold, its absorption coefficient matches very well the KTP and to a lesser extent the pulse dye laser, much better than, for example, the carbon dioxide laser, which has a very long wavelength. But laser therapy is now the preferred treatment modality, again through a microlaryngoscopy approach. Carbon dioxide laser was initially used in the defocused mode with brief pulsing mode and low power setting, 1 to 2 watts. And this is used to coagulate an offending vessel like a varix or an ectasia at 2 or 3 different spots along its length. This may be now superseded by photoangiolytic lasers like the pulse dye laser or the KTP. They can be sometimes used in an outpatient setting, and they are used to obliterate the vessels without surgical intervention, targeting the hemoglobin in the vessel's tissues, and this is usually quite effective. The KTP 532 laser can be used for photocoagulation of small vascular lesions, because the laser beam will be very well absorbed by the hemoglobin and the damage to the epithelium is minimum. It can be used in a low power setting of 1 to 2 watts in a continuous mode with 0.4 to 0.6 millimeter beam for 3 to 7 seconds, delivering a total of 3 to 7 joules. It's not recommended to use the KTP for things like a hemorrhagic polyp or a hematoma after a subepithelial vocal fold hemorrhage, because these lesions would require a higher doses and can cause more scarring because there is little blood flow inside, and the photocoagulation is either impossible or requires too much laser energy. These lesions, the vascular polyps or the subepithelial hematoma, are better treated by open surgery resection. But the KTP laser is cost effective and time saving and can provide excellent results compared with other modalities. A preferred laser for the vascular abnormalities of the vocal folds is the KTP 532 laser. In high power settings, somewhere between 5 and 15 watts. The usual is that you start with the lower watts and then titrate upwards based on the vessel responses. The mod is usually pulsed to prevent overheating of the tissues, and the pulse duration is very short at 10 to 30 milliseconds. The pulse rate is also slower, and it can be used with the fibers. Standard fibers would be about 200 to 300 micrometer for fine precision of the coagulating the vessels, but up to 400 is also possible. These fibers can be in direct contact or within 1 to 2 millimeters from the vascular markings. The closer the contact, the more the accuracy. The pulses per vessel or per site would be anywhere between 1 and 3 pulses. After a single pulse, we watch for the blanching of the vessel, and if it's not seen, 2 or 3 other pulses can be added to this. In a comparative analysis of the KTP laser to pulse dye laser for the vascular anomalies of the vocal folds, Zittels and his associates had showed that the KTP laser is actually superior in that it is easier to use. It has significantly less incidence of vessel wall rupture. It has better clinical output and can also be more reliable and less expensive compared to the pulsed dye laser. By this, we come to the end of this presentation on laser in phonosurgery. Assalamu alaikum.